I'm Karen Ellis Scharfenberg, President of the Ontario Public Health Association. I'm delighted to be here today as TOPHC MC and to be representing OPHA. This year, OPHA is celebrating our 70th anniversary as a member-based charity championing health promotion, protection, and prevention, and supporting those who are active in public and community health. For those less familiar with OPHA, we bring together a broad spectrum of individuals concerned about people's health, from those working in public health, health care, the voluntary sector, academia, and even the private sector. Our work groups are influencing public policy on a large range of issues. We offer training, professional development, networking events, and we host the Nutrition Resource Center. Thanks to those of you who support OPHA through your membership. For others, I encourage you to visit OPHA's website to learn more about how you can get involved and benefit from our various services. I enjoyed yesterday very much, and I hope you did too. For those who weren't here yesterday, you missed a great keynote speaker. OPHA is pleased to be a partner in TOPHC, and I'd like to thank my fellow partners, the Association of Local Public Health Agencies, ALPHA, and Public Health Ontario, PHO. And thanks to all of you for showing your support and attending TOPHC and submitting abstracts that have helped make an excellent program. TOPHC is truly a public health community event, and each of you contributes to its success. TOPHC is the meeting place for Ontario's public health community. Yesterday was full of energy and dialogue, and today promises to be another jam-packed day filled with hot topic talk, and more information sharing, networking, and professional development. At this time, I'd like to thank our generous supporters and sponsors for making this event possible, including the Diamond sponsor, Master of Public Health, Western University. Platinum sponsor, Shoppers Drug Mart. Gold sponsors, National Collaborating Centre for Public Health, GlaxoSmithKline, and the Propel Centre for Population Health Impact, University of Waterloo. Silver sponsor, Seqaris, and a big thank you to all the exhibitors. We hope you will visit all the booths throughout the morning. A quick reminder to download the TOPHC app on your device. You can use it to navigate sessions and play the TOPHC game. We'll be tweeting from any sessions. Join the conversation by using hashtag TOPHC2019 on Twitter and Instagram, and follow us on Twitter at TOPHC Tweets. And don't forget to improve TOPHC by evaluating the sessions. Each time you do, your name is entered into a draw for a prize. For every session, on your device, on the app, complete the evaluation and fill out a ballot to be entered into the draw. We're going to start the hot topic session now. Originally, Dr. Camara Jones was going to present on racism as a public health issue. Unfortunately, she is unable to join us today, but we are looking to address this important subject at a future TOPHC event. We are excited to have Dr. David Williams, Ontario's Chief Medical Officer of Health, leading a panel of public health experts in a very lively discussion. Dr. Williams has previously held positions, the Minister of Health and Long-Term Care as Interim Chief Medical Officer of Health, Associate Chief Medical Officer of Health and Infectious Disease, and Environmental Health Branch Director. Dr. Williams was also the Medical Officer of Health and CEO for the Thunder Bay District Health Unit from 1991 to 2005, and again from 2011 to 2015. Prior to entering public health, Dr. Williams practiced hospital-based clinical practice as a GP and a GP anesthetist at the Sioux Lookout Zone Hospital over a 3-year period, and also in the international health at the United Mission to Nepal Mission Hospital over an 8-year period. Our panelists, who have served as an advisory committee members for the last 3 CMOH annual reports, will speak on what they see as the key issues for the future directions and areas of opportunity on data, health equity, and community. Please welcome Dr. David Williams to the stage, who will be leading the discussion.
Good morning, and first thing is always get up on the stage without spilling your coffee and doing things, because if you're not on Skype, you can always hide that up, but I'm right here in front of you today. So it is an honor to be speaking at the plenary session with unfortunate circumstances. That speaker up a little higher. In that with the previous one, but this gives us a great opportunity for us to look at what's important. And I was especially pleased with what I saw with yesterday's keynote speaker and focusing on community. And that segues into very much what we want to talk about in that. And it's so great because we have a gathering here of our community of public health professionals. And that's really exciting to see the variety, the age span, and all the new people as well. And as we build our community, and we continue to do so, we're in interesting times, and we're seeing lots of challenges, much like the keynote speaker spoke about yesterday. And I know our panelists, the liveliness is, of course, in our advisory committees, and the input is extensive and wonderful. And we've done a lot of things on that. So we're going to be looking forward to having them present aspects, and then we're more, of course, interested in your questions to us that we might be able to answer in that. Part of what we want to focus on today is, and I've been working on this for a long period, because we call these 3 reports, I call them the trilogy, the community trilogy. And we started down this path, and I'll speak about that at the end. But part of it is seeing the challenge we're facing today, the breakdowns and cracks that are erupting, as one radio broadcaster calls it, within our communities. We're seeing evidence of that appearing in different ways. And the challenge is that can we, in a sense, bring back public health into the community? Or can we bring community back into public health? And for some of us, I know that when I went through our specialty training, we were called originally community medicine specialists. And there's a long debate that we should switch that over to population and preventive medicine. Because you deal with populations, not with communities. But in reality, we should and we could be doing a lot more with communities. So why are we not doing that? And that's part of our discussion today. Let's see if this is going to work. Here we are. That's the one I want. Thank you. The 3 reports, and I brought them all, so they actually physically exist, including the one we just put out, deal with 3 subjects that we looked at going through the whole idea of saying, what do we know about community? More importantly, what we don't know about community. And that was challenging us all the way along. And I'm going to talk about just quickly those 3 because I don't want to take up more time than I have to, because I want our panelists to going to join me on in a bit, and they're going to present their aspects in there. The panelists represent only a few of the different people we've had as valued advisors during the formation and the putting together of these 3 reports. And we tried to capture as much as we could from those inputs. So we took these ones here: mapping wellness, improving the odds, and connected communities. If we look at mapping wellness, that was the first one. And this travel and this journey for myself working with community goes way back. When I first started doing as a clerk, then as a resident, and then as a staff doctor at the Silcote Zone Hospital, now over to Minneowi Hospital, we didn't have one community, we had a number of communities to go to. And it impressed me that each one was so different from the other. They were unique, although at first they seemed the same, they were not. And some were much more dynamic than others, and I couldn't understand that. And of course, what I couldn't understand at that time, behind it all, was the impact of the residential school system in that, and the decimation of community in those communities. And to see that resiliency now, to see that building forth, and part of our advisory committee in this last report was Dr. Suzanne Stewart, of course, at the Wakawani's Bryce Institute at Dalalana, and we bring that input in and understand that. And for me, it's been a journey of well over 40 years of watching and seeing this resiliency reverberate and come back in as they try to recreate the community that they're aware of, in spite of the injury and decimation due to the residential school program and other systems. So that was part of that journey there. But beyond that, with data and understanding, if we don't understand our communities, it's very hard to have a dialogue with the community. We think communities are municipal boundaries and they're just physical living spaces. And that is a false assumption. There's actually communities within communities. But do we understand that? I remember when we were in practice out there and we had a community that had a lot of deaths in young people, young women especially, in a very short period of time. We didn't know what was going on. It was an infectious disease issue, but there was a behavioral side to it. We did a detailed community survey with the permission of this community. And those results, I'm not going into details, revealed some things that were very startling to the community, upsetting to the community. Nevertheless, they had to say, this is our data. I don't like it. We don't like it, but it is. Therefore, we have to take ownership of it. We have to respond to it. It helped us to understand better because we had false assumptions and they had things to work on. So I saw the value at that time of how data accurately attributed to the community, valued by the community, was the start of a conversation, allowed for continuing conversation, the edification of the community, the edification of the professionals, us and the staff, to help us best to move alongside, to help them work with their community efforts in that. So mapping wellness was talking about the value we need, and I still am pushing forward on that. Our data systems aren't as good as they should be. They're not as granular as they should be, and we have to try and address and obtain that for us, and especially for you and for your communities, if you're going to have that dialogue. So we're still driving forward on that. The next report took us on a different direction, and this was dealing with issues around that within our communities, they're not homogeneous. Within our communities, we're seeing increasing clustering of groups in disadvantage, vulnerable, priority, not just one or two here and there, but because of the changing social demographics, because of the changing economy, we're starting to see some resurgence of areas you might call socioeconomic ghettos and gathering. These ones are not communities, they are not connected, and as a result are highly vulnerable in that aspect. What impressed me also, going back well over 15 years, is the work by a classmate of mine, Dr. Corey Newdorf, and his work in Saskatoon that looked at these issues around high priority neighborhoods, and that there was a difference in not only the general looks of those, but also in mortality and morbidity, not by a few percent, by sometimes up to 800 to 900% difference between one neighborhood to the next. And that is really unacceptable. And we had that with related to infectious diseases, we would do something. That's why we used the outbreak model to look at it. That was not a comfort zone for most of our staff and people out there. They said, this is like you're crossing over an area that's not permitted. If it's not totally prevention, you shouldn't deal with it that way. And yet, sometimes when we're dealing with disparity, inequity, and those issues there, we have a sense that if we wait for society to get everything right, there's nothing else we can do. And my challenge for us and for myself is that that's just an excuse for inaction. We need to do something. The challenge is, do we have the tools to deal with it? Do we have the ability to deal with it? Do we have the information to deal with it? And I'm not sure we do. We have to continue to drive at those, and that's the other value of the report, looking at that. We had one similar, looking at those issues, another example where we had asked to go to a school where all of a sudden there was a number of illnesses in the grade 7, 8 female students, and some had hospitalization, 2 had had exploratory surgery. And we wondered was it environmental cause, what was it? We did the investigation, and we found out because our nursing staff had access into the community. They understood the issue was really because they had merged a low-income housing group into a middle-class group. The students were all buying in one classroom, and there was some who had suffered a fair amount of violence in their youth, and there was circles of violence among the female students among each other, so that students were harassed in the class, in the schoolyard, on the way home, and at home. And their only way out was to deal with it through illness and physical fitness. And so we were challenged again on that one, we didn't know initially what was going on. We found out what was going on with the data and information. I'm not sure we actually did solve the problem in the long run, because in the end, those people had to leave the school. And so we solved the issue, we didn't solve the problem. And that's part of the challenge we have to wear and walk through that on that basis. The most recent report on that one there is Connected Communities, the one we just put out. And on this one here, we really had to challenge ourselves to say, in our evolution of society, and for some of us who've been around a few years longer than others, we've seen the fact that what we used to have in sense of community is no longer there. With movement, jobs, the disruption of the nuclear family, economic issues and movement in that, and the IT systems that are out and social media, we see a continual push of the autonomy of the individual and the isolation of the individual at the same time. And we're seeing the consequence of that, where people with loneliness and that have the same high mortality rate as someone smoking, for example, 15 cigarettes a day. It's not just a benign issue, it's a big issue. And we're seeing that across in many different sectors of how we're going to deal with that as people find they're isolated. Communities are such that you don't feel safe to let your 6-year-old go out and play in your front yard. You don't feel safe to let your child walk to school. You don't feel safe in your neighborhood. Why is that? Well, you saw something on the internet that happened over in wherever. And so people are living in a constant state of anxiety. And what do we do to do those things? How do we handle those in that sense there? We have individuals acting out in isolation, whether you're driving a van down a street or you're getting a shooting range on another one. These are individuals that got more and more isolated, got more and more partitioned off, and did not have the supports of community in those aspects to help through that situation. And yet the communities, I felt, responded in a very excellent way to those issues and matters. So it's not that the glass is half empty. It's there. But how do we take advantage of that? And how do we do that? I haven't seen my sign message here. So as we look at these things, and we look at this trilogy, one of the aspects I've been trying to look at is, as we deal with public health, the change in public health, the changes in public health as we rise to these new issues. For some, the changes have already started to happen. We spent 2 or 3 years looking at the Ontario Public Health Standards. We reviewed them extensively. There was a sense that we should protocolize, to use that word, everything. And protocols, someone introduced it a few years ago. And that was for more the protection side, to deal with things that we need to do the same every time, all the time, throughout the province. And that was true. But we struggled with chronic disease. We struggled with health promotion. How do you protocol those things? And the paradigm shift was to say, let's look at something different. Let's look at standardized flexibility. Let's ask our health units, free up our health unit staff, our public health staff. Look at your data, look at your communities, and you decide what are your priorities. You decide where your vulnerable populations are. And what we want is not, we're going to, because everybody's accountable, to look over your shoulder on every detail. We just want to know that the process was robust. And you're doing your annual service plans. That's just the first year this is going through. So already the change in the functionality of public health is occurring. Speaking to a number of different ones, some embrace this with great enthusiasm. They're reallocating staff and resources to get to those. Some are less than sure about it. Some are saying, but where's the menu? Where's the prescription? How do we do it? And some say it's great. I just don't know if we have the capacity to get there. And so it is a stretch for our sector, as we're asking the public health sector here to engage in your communities, to assess your communities, and with your knowledge, with your skill base, with your passion, to address those as you see as a priority basis. So in a way, I've called it freeing up public health to do what public health needs to do. And the fact is that we don't need, with all this expertise in the room, to tell everybody what to do in that sense. We just need you to do it well and to give us evidence that you're following that process. So that's some of the shifting changes. And as we see the other things that are going on, we've added also in there aspects of health equity in the standards. We put in need to have relationships or contact with Indigenous communities. And yes, and to talk to the health sector on that aspect there, because it's a sector that's struggling. And when we talk about hallway patients and all that, is my impression, if you look at the makeup of those hallway patients, 15 years ago, they weren't there. We've always had, being the hospital's director, we've always had some people in the hallway for 24, 48 hours while bed when they're discharged. It's not a totally new thing. But when you're getting people put in there and they're there for 6 weeks, that's a new entity. And if you look at those people, they're makeup of a certain area. And we have to understand that better. Because in the essence, the best way to stop hallway patients is to stop them going into the hallway. And how do we do that? And that's something that I think our challenge that we can rise to. Why? Because it's prevention, it's promotion. And I think we can do that. Finally, wrapping up here on some things here, I've given you this chart here. One of the things I had to do coming back into the job as the Chief Medical Officer of Health, and having put out previous CMOH reports, was to ask myself, what good are they doing? Because I'm asking myself that question. Are we making an impact? What's the value of CMOH reports? This is a bit of a graph here showing the ones over the last number of years. And they all talked about important topics. They talked about things that are really reviewing things of our normal comfort zone that we feel is important, ratifying what we need to do. Even my first one coming back on immunization, very familiar, but pushing the aspects there. What we did is look at those areas that we're not comfortable with. And my reports to the legislature, ergo to the public and to the sector, are not to be the final penultimate comment. It's just the start of the conversation, raising more questions and answers, because it's like a gathering like this. And the ongoing dialogue with our community of public health professionals here in the room, we have, I feel, full capacity to come up with many answers that I don't have. You'll see in the report, there's many aspects, all three reports, that there were you in the field and others are doing excellent examples of what's happening. And also we're going to hear from our guests, our panelists, talking about their perspective on the matter. So I think we have the necessary vitality, the necessary skill base to drive this forward in a new paradigm shift with public health, moving into the community and asking the community to come into our area there. So these were a new set of reports that were different than our past ones. They raise a lot of questions and issues. And in that sense, I'm looking forward, as I have been, for the answers. There are system things that are our responsibility to bring in, and there's things that we need from you of examples and raising questions and issues to say, what about this? What about that? And all these aspects there as we deal with communities and community. On our last report, for example, to challenge us on that one there, and I'm not going to put it back up again, we had those circles showing communities. And we had to challenge ourselves because we have communities that are geographically located. We have communities that are connected by culture, by religious groups, by those things that are maybe not next door to each other, but are connected nevertheless. And another one we tried to get our graphic person to present there was people that are connected, and instead of a circle, I wanted a big ampersand. Because our sense is that social media and IT is an enemy of community. And in some ways, reading on the book of Thank You for Being Late, Friedman, his point is that our technology has moved on so fast, we have not put the social cornerstones, the social structures in to handle that technology. And so therefore, I'm not a Luddite on that sense. I think that some of that can be useful. Can you have a functional virtual community? Not the current dysfunctional, where people are connected with everybody, but never talk to anybody. Where all you do is you put on Instagram, whatever your thing that you want to show, which is not really you, it's your face you're putting on, and they really don't know. They know the good side, but they don't know the things you're struggling with. They don't know your insecurities, they don't know your problems. And that's where community members can come together on that. Our whole big push now on mental health, and Ministry of Development, that is that how do we do that? And how do we engage that? Because now the community is embracing that. And so it's no longer stigmatized. Our struggles with the opioid crisis, as I raised back 2 years, now 3 years ago in Ottawa, is in Ontario, we didn't start with fentanyl. We started back in 2002. And we've been growing ever since. Why? We started before even the big push of OxyContin. And we have this ever-increasing number of people that are on these issues. And you get a lot of young people saying, unless I take some drugs when I go to school, I can't focus. This to me is a challenge. This to me speaks to a need for public health to be motivated. We have an epidemic of anxiety. Why do we have that? And you say, well, that's just people anxious. No, it's people using drugs, people getting addicted to drugs, people then come to the sequelae and cons of drugs. We can look at the opioid crisis, but what's the issue behind it and the issue behind the issue? And we have to ask ourselves those questions. And there's a lot of system problems that we have to address in Ontario. Ours is not the same thing as BC. They have their own challenge unique, but we have a bigger problem here. We've been growing that for over 15 years. And now we have to try to turn the tide on that. Now we have other things coming in, cannabis and different things. How is the society, how's Ontarians, how's the public health community? Are we going to engage the community in this dialogue? And you see these community dialogues occurring, even in the stalwart areas of vaccine hesitancy. As people are saying, this is a community responsibility. And we talk about the different things about social determinants of health, and I've been toying with my staff and saying, maybe we need to talk about the CDOHs, the community standards, since the social development of health, the community development standards of health. And what are those? And how do we do those? So I'm pleased to be able to be here today. I'm looking forward to the ongoing dialogue from these on the years ahead and to hear all the things you're going to be doing. And I'm looking forward to having our panelists, and I'm saying my time's up on here. So I'm waiting for the discussion and to hear what they have to say, because I have found in our advisory groups where we started to talk about these issues to say, what do you think? The conversation just went. And there was no end to the passion that the different people brought to the table and others who wanted to come to the table. And when I've engaged different people out in the field, that passion's there. It's always been there. Our public health people have always been very passionate about that. And one of our challenges, my challenge, is that how do I ensure that our public health people can live on that passion, they're concerned about community, and be able to engage in community, work in the community, and to embrace that. So then how do we equip you, and how do you equip us with information material so we can, in the community, our public health practice, hone each other and do a better job all the time. So with that, I'm going to finish off there and not take up more time than I have. There's the 3 reports. You can get them online. I'm going to call Catherine Fraser up now, who is going to introduce the panelists and try and keep us organized.
Hi, everyone. My name is Catherine Fraser. I'm Dr. Williams' Senior Communications Advisor, and I'd like to welcome you here this morning. Thank you for coming. I'd like to introduce a fantastic group of panelists, what I like to refer to as the rock stars of public health. Just so we're clear, Heather is head of the band because she's worked on all 3 reports. We've had the privilege of having each of these panelists on the Senior Advisory Committee of one of the last 3 CMOH reports that Dr. Williams described. They represent a diverse range of insights in the areas of health equity, data, and community. Sorry, it's not going to be in order. I didn't write my notes in order, so I'm going to introduce, and by the way, these are very short bios. Obviously, these people are much more decorated than I'm going to go into. You can look them up, right? John Garcia is Professor of Practice and the Associate Director of Professional Graduate Programs at the School of Public Health and Health Systems at the University of Waterloo. Chuck Gardner has been the Medical Officer of Health for the Simcoe Muskoka Health Unit since 2005. Laura Rosella, on the end, is the Principal Investigator and Scientific Director of the Population Health Analytics Lab. She is Associate Professor at the Dalla Atlana, sorry, I always mess that up, School of Public Health at the University of Toronto. We know Dr. Williams. Dr. Manson, Heather Manson is Chief of Health Promotion, Chronic Disease and Injury Prevention at Public Health Ontario. Kwame McKenzie is CEO of the Wellesley Institute. So we're going to start with some opening remarks from each of the panelists and give them an opportunity to share their perspectives on the issues of data, health, equity, and community, and then we'll follow it up with a Q&A, and we hope you'll step up to the mic to ask some questions. Do we go in order? Laura, do you want to start?
The wrong seat. Okay, I'm happy to start. So thank you very much for this opportunity, and just congratulations, Dr. Williams, on 3 really excellent reports. So I'm just going to start off with my perspective as someone who has believed since, the first statistics course I took 20 years ago that data is a powerful element of change. So I'm going to focus my remarks on data, and I'm going to specifically talk about 3 areas briefly. First, just emphasizing what actually is happening now when we look at the data, what we see from the reports and from our understanding of working with these data. Second, to talk a little bit about why a predictive framework might actually be useful to start integrating in the way that we put data into action. And then I'll last talk about the community and social support, which was really the focus of the last report. So, one of my last big projects, we started off by using multi-linked population-based data to look at mortality trends. And I'm going to focus in on premature mortality because premature mortality pretty much involves preventable deaths. So deaths that through a public health prevention framework or a social determinants lens or good access to medical care could have been avoided. And I'll touch about what we found in those reports, and some of those findings are in the reports that Dr. Williams mentioned. But first, we started that project by asking decision makers what they wanted us to do with the data. So instead of approaching it saying, these are our questions and this is how we're going to do it, we said, tell us what outputs will help you make your decisions. And from that conversation, we got some excellent insights and really emphasis on the importance of local data, but also zooming out. So this idea that we have to zoom in, get local data, get the local conversations going, but at the same time, stand back and understand where that fits in the broader context of Ontario. And what that looks like in Ontario right now, if we focus again on premature mortalities, is that we have increasing absolute and relative inequities in premature mortality. That's what's happening now. And so just for a moment, just let that sink in. So premature mortality has reduced, although in Ontario, I'll say that we're pretty average compared to other places around the world. So we've made a reduction, 20 or 30%. But the inequities between those that are the best off and the worst off from a socioeconomic position are getting bigger from a relative and an absolute perspective. And the way that that happens is that gains are happening, but those that are the most disadvantaged are benefiting least from those gains. And so that's kind of the exact opposite of all the activity we've been focusing on health inequities. So why is that happening? Is it because we're not aware? No. We get criticized actually all the time, which I don't agree with, for documenting inequities too much. We just study it and we keep documenting. But no, so we are aware. We've been documenting these things for a while and we continue to do so, and that's actually important. Is it because there's no solutions? Well, actually, these 3 reports demonstrated really wonderful, creative solutions that are happening across communities all over Ontario. Amazing thinking, amazing initiatives. So are they not being scaled? Are they not having the impact that we want? Is it because the healthcare system isn't thinking about it? Well, I've actually noticed that the healthcare system is thinking about the social determinants of health now more than they ever have in this province. So where's the disconnect? Why are the trends actually going in the exact opposite direction to our action with equity? And so that's just a question I'll pose to the panel. Maybe we can touch on that. So thinking about the predictive perspective, and we did input some of that into these reports. Why is prediction important? So it is one way that we can take data and put it into action in a slightly different frame of mind. And it serves 2 purposes. So first, it really helps us reinforce the link between the work that we do in public health and the impact on the healthcare system. And we've been doing a lot of empirical work on that to show that everything that everyone in this room focuses on every day actually is critical for a sustainable health system, for reducing healthcare costs, making sure our population is healthy. And we keep reinforcing that. And the predictive models have been useful for that purpose. But also helps us shift from, okay, now we know what's happening, what can we do with it? But where we need to move is what in engineering they talk about as the prescriptive side. So you have the predictive, you know what's happening, you can predict what's happening with it, but how do you use it to inform decision making? And prescriptive analytics, I think, is an area where data can really be used in a more impactful way. Last point, talking about social and community, which is again the emphasis of the third report, which I really liked. And I came across this in 2007 when I was working on a report led by Dr. Manuel, trying to benchmark Ontario against the rest of the world in terms of what's the healthiest jurisdiction, how does Ontario get there? Lots of interesting findings, but one of the key ones is that the places that had the healthiest populations were the ones that had the strongest community and social support systems, but they happen different ways. So some countries, it was a family-based focus where you have this intergenerational support in the beginnings and the ends of life, and it's all centered around family. Other societies, it's the strong social support systems that have been deliberately engineered through government actions, policy, and a well-funded social support system. So it happened very different ways, but the outcomes were consistent. These were the healthiest populations. They also happen to be the happiest populations, which in our latest work, we've done 2 studies and third one on the way, looking at life satisfaction, which is a subjective well-being measure, and how strongly that correlates with health equities, population health, healthcare costs, everything. And I've actually been surprised about how strong these associations are. And when you unpack, well, how do you improve people's life satisfaction? Well, it's about people feeling like they belong to the community, when people don't feel left behind, when they have the freedom to speak and be who they need to be in society. So those are big structural issues that can't be just solved overnight, but really the secret to maybe unpacking some of the health inequities. And just on the closing thought, I'll put out that my impossible question is sort of, why are the trends going in the opposite directions of our action? I'll put one piece of the puzzle there, not the only piece. And maybe it's because we could be using our data a little bit better, in that we document what's happening, we look at what could be happening, but how are we actually matching our activities, our interventions, who we target, how we target them with what we see at the data? And I think that if we can get that puzzle piece working together a little better, we might have a little more impact at the population level. Thanks.
Hi, well, thanks very much for inviting me. I must start by saying it's been a pleasure to work with Dr. Williams and his team, and I've been honored to be part of the last 2 landmark reports. And also I'm very excited to be here because this is my first topic, so treat me nicely. Now, let's get you interacting a bit. How many of you have been to London, England? Oh, right. You paved well, eh? And how many of you have heard the phrase, mind the gap? Yep. And how many of you know why the gap exists? So, the gap exists, a simple story is that carriages are straight, but some of the stations are curved. And if carriages are straight, but some of the stations are curved, either that way or that way, some bits of the carriage are going to be closer to the platform than others, so you have a gap. Now, the gap's been there since 1863, okay? And about 300 people fall between the gap between the platform and the carriage each year, about 300 on average at the moment. And there are loads and loads of possible solutions that you can think of to sorting out the gap, but none of them are taken up because they're all considered to be too expensive. Okay? So it's not that we don't know what the gap is, it's not that we don't know how to fix it, it's that people think it's too expensive. And so the preferred solution is to tell you to mind the gap. Okay? That's the preferred solution. Responsibility taken from the people who produce the gap to the people who experience the gap, okay? So that's the simple solution. The point that I'm making is that if we actually want to get rid of the gap, it's not just a matter of measuring the gap. It's not just a matter of understanding why it exists. It's understanding why it persists. And understanding why it persists gets you to produce solutions that can work in the real world. We have to have a really cheap solution, or we'd have to change the way that the London Underground does cost-benefit analysis, or we'd have to change the value structures of the London Underground, and we'd have to be asking them, are you really comfortable with the fact that you have a publicly owned, publicly run system that allows over 300 people a year to fall between the train and the platform, and you've been doing it for 156 years? Okay? So these are the sorts of questions that you would ask and if you wanted to change the values. And the reason why I moved from clinical work and then running a hospital to working in Wellesley Institute is because we're interested in not just why the gaps exist, but also what you can do to change those gaps. And I'm here, as I was on the panel, to try and move people from their comfort area, but to their passion area. Because most people are passionate in making a change, and that's why I presume you're in your job, and that's why you get up early, in the rain, in a dark room, to be here listening to me, okay? But I'm not telling you anything you don't know. I got interested in this area by reading public health, by reading some of the work of, say, for instance, the Columbia team, Phelan and Link, who are interested in the idea of how you deal with complex problems, and this idea that you don't only deal with the outcomes and the processes, but you have to go to the fundamental causes if you really want to make a change. So this idea of attacking the fundamental causes in order to produce change. And I would argue that disparities, and the disparities we're seeing increasingly in Ontario, are down to some fundamental causes, and the CMOH's report do an excellent job in detailing the better data we do, understanding the problems, understanding the geography of the problems, and understanding that there are inequities. But I get haunted by whether we really need to move from that to saying, well, why do these persist? And this is where it becomes uncomfortable for a lot of people. Because we know that the fundamental causes of the disparities, they're political, they're economic, they're social ideologies. We create the inequalities through employment, through our tax system, through education systems, how we fund social support, housing, economy, and the economy of food. We create it through social stratification, whether it's through race or gender, and we create it through the differential functioning of our health and social systems. And those are choices. And you could argue, and I would argue, that when we're talking about social determinants of health, that divisive social or economic public policy is a social determinant of health and is something we should give attention to. And that's where people start getting out of their comfort zone, but hopefully into their passion zone. Because our society isn't defined by just what we do, it's defined by what we don't do. It's defined by what we tolerate. And public health has taught me that well, actually my wife has taught me, that we can't properly fight infectious diseases without clean water and good sewage systems. And we can't fight health inequalities without social and political systems that promote equity. It just doesn't work. So the question that haunts me from the CMOH's reports is that if we understand this, if we understand what the fundamental causes of health inequalities are, what is public health actually going to do about it? What's it going to do with this knowledge? Do we have the right tools? Do we have the energy? Do we actually have the enthusiasm to deal with the fundamental problems that are causing disparities? Or, are we going to be silent? Do we want to link our science, passion, and advocacy to make real change? Or are we going to have the bystander effect where we think somebody else is going to do it and nobody else does? Do we want to manage sideways? And, yes, we do have to work with communities, but what about the people who structure communities? Or do we want to manage up? Or do we just want to say to communities, mind the gap and fill in the gap yourselves? Thank you.
So, a little challenging to follow your wonderful presentation, but I'm going to give it a try. The first thing I wanted to say was, Dr. Williams, thank you so much for, first of all, inviting me to be part of your advisory committee. It was an honor and a privilege to serve. And congratulations on the trilogy of reports. I also wanted to welcome everyone in the room, many of whom I've got to know over many years. And I wanted to say that it's Public Health Ontario's 10-year birthday, or we've just rounded that corner. And so that gives a moment to pause and to think and to reflect and even to celebrate on some of the things that we've done in the area of data, equity, health equity, and community. So I wanted just to spend a moment pausing to think about that. So as you all well know, our mission at PHO is to enable informed decisions and actions that protect and promote health and contribute to reducing health inequities. And those words, contribute to reducing health inequities, are in our mission statement. They're in our legislated object A. They mean a great deal to Public Health Ontario and its staff. Now, we contribute to reducing health inequities and to data equity community by kind of leveraging all of our legislated objects. So I'm going to just give you a few snapshots. We have snapshots. We've got staff that work on online visual displays. These are interactive, web-based, sort of map-based displays of data by public health unit, by Ontario, and those look at trends over time as well as over geography. And we've also now got health equity related snapshots, in case you haven't seen it. We provide training. We initially supported the Ministry of Health in developing a training module for health equity impact assessment. We went out and did training in local public health units. Subsequently, we've developed an online 5-module course in health equity impact assessment. And we provide ongoing support in this area. Through my colleague Samia Abdi would be one person that I would mention. In addition to that, we undertake research. I wanted to call out my colleague Dr. Brendan Smith's research, where he's modeling the impact of various nutrition policies on health equity related outcomes. I wanted also to call out my colleague Dr. Pamela Leese's work, her recent scoping review on interventions to address the opioid crisis within communities, community interventions. We build capacity. We build capacity by going out and supporting communities and organizations to collect data that's relevant to them. We build community. And I wanted just to reflect for a moment that you are our community. You're part of our community, a really important part of Public Health Ontario's community. And we build community with you when we convene you, for example, at TOPHC, through our grand rounds, through communities of practice, through locally driven collaborative projects. Our public health practitioners are our important community. Now, in addition to all of that, really our goal and why so many of us have signed up to work at Public Health Ontario is because we are passionate and committed. And we're committed to our mission and we want to make a difference through our mission and mandate and through our legislated objects. That being said, we know that we can't do it without our key partners in policy and practice. In other words, we can bring all the data, the evidence, the capacity building that we can, but we actually need all of you at the coalface. My colleague sitting right beside me here, Dr. Chet Gardner, at the coalface of practice of equity, data, and community to really make those interventions and to implement. Now, we've learned that when community has a role in collecting data or in identifying what the important data is that should be collected, or when the data that they've collected is relevant to them, they're able to have substantive and real impact on health equity. Now, there's a phrase, it's a well-known phrase, knowledge is power. I was thinking when I was preparing my comments last night that I might say it's attributed to Sir Francis Bacon or Thomas Hobbes or others, or maybe their wives and partners, we just never know that sort of thing. But I wanted to say that we know that knowledge is power and data are power. But I would also say that power frames the importance of knowledge and the use of knowledge. Power frames how we use knowledge. So when we do what Dr. Pinder-Hughes recommended so passionately at the very end of his presentation, center around youth. When we listen to and include the voices of people with lived experience developing community opioid plans, when we center around the needs of Indigenous communities and what data they want to collect, when we bring community members into the table at the very beginning in the planning stages, again, to find out what data do they want to collect, what are the interventions that they think are important, we actually begin to start to address some of those underlying structural issues. We begin to share that power and privilege with those groups. So I agree that that is challenging. These are challenging places to go, but I would just encourage you all to go into these places. Engage with your communities. I know you do. Engage with people with lived experience. Bring them to the table. Engage with youth. Center around youth. That really concludes my comments, but you can see I'm really passionate about this, and I'm so thrilled to be known as a rock star. Thank you.
So good morning, everybody. And I'd like to start by thanking Dr. Williams for inviting me to be part of this panel today and to be part of the creation of the last of his trilogy reports. And I'd also like to commend Heather for highlighting beautifully the importance of Public Health Ontario. Congratulations on Public Health Ontario for 10 years of supporting us in the field. I certainly recall the days before Public Health Ontario, and it's never ceases to me to be a miracle, the contribution that Public Health Ontario succeeds in achieving for us, enabling us to do much more with data and increasing our capacity. So congratulations to Public Health Ontario for 10 years. So I came on for the last of the trilogy, all about connected communities, and I do find that to be a stirring topic. The whole concept of loneliness I find to be emotional, I would say. I know some people who've found their way in their lives to be quite lonely, and it's really a hardship. It's a hardship for people to be lonely, to be disconnected and not feel part of our community of friends and family. And it has a real impact on their health, as we saw from Dr. Williams' report. And I think it's an important way to perhaps reframe the social determinants of health, to look at it yet again in a new light and to ask ourselves, what else can we be doing to make a difference? And to draw upon the earlier content of the trilogy, which is data. What can we bring in the way of looking at our communities to look at connection and to look at data that gives us a better understanding of the issue in our communities. And so when I look at my own community, for one, we've started looking at neighborhoods, which is something relatively recent for us. There was certainly a time in which we just looked at the whole of Simcoe Muskoka. And now we're getting more granular, perhaps following the lead of health units that were cited in the earlier reports, such as Sudbury or Durham, and using the data sets from Public Health Ontario to be able to achieve that. And we find that there are correlations, for example, with income or the degree of prevalence of low income in neighborhoods, with a sense of disconnection in their community, that those parts of, say, the city of Barrie that have the lowest income have the highest degree of disconnection, of a lack of connection. And they also tend to have much higher negative health outcomes, mental health issues, even life expectancy. There can be a 5-year difference between the best connected neighborhoods, the best off neighborhoods, and those that are at the other end of the spectrum. Which I think is a challenge for us then to ask, what can we do about this? What we can in turn challenge those communities? What can the councils be doing about this? It can arise as a crisis of the day, such as opioids, but when you look at opioids and where they land, opioid toxicity, it tends to fall along the lines I've just described, and then to get deeper, you need to ask what change needs to happen in those areas of our communities that are most affected with disconnection and low income and the health sequelae. What can councils do? What communities do? What are the solutions? In public health, we do a lot of advocacy, and we have advocated on the topic of low income over the years. We've advocated for guaranteed annual income, and we came very close to having real movement on that. I would say that if you look at income and income disparity and the tendency of the concentration of wealth in the last half century or so, there's real data, once again, that quantifies that. There's data from the Fiscal Accountability Office of Ontario that shows that we've had a 49% increase in our GDP over a 35-year period. So that's a huge increase in our collective productivity and wealth. And during that period of time, our median income, like where the halfway point and below resides in the province, hasn't changed at all. So in other words, it's all gone to the upper half, probably more so to the upper 1%. And what do you do about that? I think that's a great challenge for us as a society, and certainly fits with some of the reading I've done by people like Thomas Piketty, who wrote Capital in the 21st Century, or Walter Scheidel, who wrote The Great Leveler, who explore the very powerful economic forces that drive that. So I don't know what the solution is to that, but I do know that public health always rises to great challenges and often overcomes the odds. So that's income and how it correlates with loneliness and disconnection. But another great passion of mine is the built environment, and I was happy to see there was some content there. And perhaps I had something to do with that. I was pleased. And to me, that's an area where you can make movement on a lot of fronts, including loneliness and disconnection. And we've been literally driving ourselves over the last half century into sprawling communities that essentially tie up our time and lose space, public space, for us to come together. We lose more and more time to commuting, for example. And so I would put forward the challenge, what can we do to rebuild communities so that we have social spaces again? Beautiful spaces where we come together, like the town squares of old, the plazas and the piazzas and the town squares, the places where we all flock to Europe to see the great historic cities of Europe. They have these spaces because we always used to make these spaces, places where people of all ages come together and enjoy the beauty of the space and simply enjoy being together. I believe that we enable or impede the ability to come together with how we structure our communities as well. And Dr. Pinderhughes did touch on that as well yesterday as one of his themes. I would say that one of the appealing aspects of this topic is you can literally show it with photographs, and if you come to our follow-up continued discussion session, perhaps I'll have the opportunity to throw up a few photographs of plazas and squares that I have loved in the old world of Europe, in northern Spain, where you can see children playing in such a space, coming and going freely because it's safe, it's car-free, and family members are around the periphery enjoying themselves. Or you can see an almost identical situation in Cuzco, Peru, So it does exist in the New World as well, but it tends not to be in the English-speaking world. We have a harder time in the English-speaking world doing this for ourselves. But we're not completely bereft of it. There's Bursky Park in Toronto, for example. And so if you come, you may see a couple of shots of Bursky Park and perhaps some people that you know. So I think those two tasks, dealing with low income and dealing with the built environment, blend well together, and both are essential to helping to create connected community.
Microphone. It's a pleasure to be on this panel, and I appreciate having the opportunity to have been involved with the. Okay, is that picking it up now? Okay, my apologies. Okay, so I just wanted to say that I'm delighted to be on this panel and to have an opportunity to comment on the report. I appreciate being involved with the second report that you identified. I'm going to speak a little bit about my reflections on the significance of Chief Medical Officer of Health reports and their role in the development of public health practice in the province. And I've got a number of questions that sort of come to mind as I reflect on the reports. So the reports actually do set a stage and sanction very much a direction forward for public health in the province. There's no question about that. So the focus on essentially local planning, using local data with a commitment to continuous improvement of those data, a call to action on health equity, and a focus on building community, creating a sense of community, and more important, an important role for public health in enabling that to occur, are all the right direction in my view. I think that Dr. Williams' reports, the trilogy, as he described them, carry a lot of weight. I mean, it goes without saying, people that are in this room know that Dr. Williams is the chief public health official in this province, appointed by the legislature of the province, ADM responsible for population and public health, and has oversight of the entire public health sector. In many ways, he has much more authority than the U.S. Surgeon General, but I do see that that these reports serve much the same function as Surgeon General reports have in the past. They set an agenda. In many ways, for us, they're the clarion call to action in a particular area. Public health needs to pay attention to this. This is a big deal. I recall when the first Chief Medical Officer of Health report was released many years ago in the 90s. It was actually a key communication strategy in advance of the Ontario tobacco strategy. And I should say that I suspect there's no coincidence that these reports are entirely consistent with the public health standards, the guidance documents, the protocols, and so on. Some of this is old hat. Some of this is not new to the history of public health. Some of you will certainly know the history of public health and be able to think about Rudolph Virchow's recognition of the social and economic and political causes of ill health, as well as the need for political action, social action, in order to address those underlying causes. So this is embedded in many textbooks of public health and social medicine practice. So in many ways, it codifies what we know public health needs to do. And as many of you well know, the sponsors of this conference, apart from Public Health Ontario, have advocated for many years about the importance of health equity and evidence-informed practice and for mental health reforms, and to have that recognized within public health. These are big gains that have been made in the recent set of public health standards. And so for those of us who are working in public health, they reinforce what we think is important and continue to justify the work that we do. But it's now sanctioned and important. What remains, however, is how public health, that is the public health system, is actually going to take the game to the next level. It's no longer simply acceptable to understand the social determinants of health cause ill health and are responsible for the massive inequalities in our society. We need to do something about it. So what's that going to be? Well, as a public health professional and educator, I'm optimistic about the future. Things are different now, I think, as a result of the focus of these reports. Local data, a focus on, and a call to action on health equity, and mental health reforms, and focus on public health as a social concern are now normalized. They become part of regular practice in public health. So this is a milestone in the development of public health, in my view. We do have the reports and the standards, as I mentioned, and we have a growing provincial and national network of people that are concerned about health equity. And we have public health organizations that are actually prepared to advocate to advance practice in each of these areas. These are positive developments. Questions, though, arise in my mind. Lots of things to think about. The agenda to address this complexity will be defined not on how we think, but how we act. We have to do more than mind the gap. What are the mechanisms, first, what are the local issues and concerns that will actually emerge as the priorities in public health across Ontario? We hear anecdotes and cases and so on, but we don't have a system to actually scan and pick up what the major issues are. We need that in place. What are the mechanisms that public health, and I use capital P, capital H, public health, this is the institution of public health. What will the mechanisms be, which mechanisms will be seen as legitimate for public health's own action and direct involvement in these issues? Will they be social? Will they be economic? Will they be political in nature? What are the limits of public health involvement, and how can public health actually support the action of others if they're not able to take action? Basic income guarantees, dealing with the structural determinants of trauma that we learned about yesterday, dealing with racism are going to require us to go beyond our comfort zone. Where is that comfort zone? How do we define that comfort zone? And how can we define our roles? Will we abandon a role in addressing healthy living with a particular emphasis on leveling up and eliminating disparities in tobacco use, for example, or other drug use, or food and food security? These are not separate from social determinants of health. They're embedded in the social matrix, and they need to be addressed in the process. I would suggest that they're not an either or, but really a both and kind of proposition that we need to think about. But how will we do that? How will we not leave the dirty word lifestyle, something that I've had to struggle against my entire life because I've worked in tobacco control? That's old hat. Well, it's not. It's about politics and economics from the very beginning. Will a system emerge that will actually facilitate robust learning? And I underscore robust learning, that will actually share innovations that are developed locally. And I'm talking about knowledge exchange structures, I'm talking about training, technical assistance, and peer learning networks. We don't have a public health promotion resource system anymore. Public Health Ontario is doing good work here. Maybe we need to see expansion on that. I'm not speaking on behalf of Public Health Ontario. Well, we'll see where all this stuff goes, but I'm optimistic. In fact, how can you work in public health if you're not optimistic? Okay, so that's all. Is this one working?
Hello?
Figure out. Hello, this one's working.
Hi. It must have been because I threatened to do my version of Gwen Stefani's Holla Back Girl that you turned off my mic. Dr. Williams said no, so fine, I get it. I can't do that. Thank you. It was great to hear such an interesting range of insights. Thank you all. We would like to kick off the discussion with some questions. We're going to invite people up to the mics if you'd like to do that, but I'd like to kick it off first with a question. Panelists, please feel free to jump in to the discussion at any point. We'd like to kick off the first question with the issues around public health and well-being are recognized as being impacted by complex dynamics between the social determinants of health and large systemic pressures. How does public health equip themselves to tackle these complex and daunting issues, particularly those that appear out of their traditional scope of practice? Yeah, that's a good one, isn't it? Jump in.
Nobody's jumping, so I'll jump.
Go ahead. Go ahead.
So I've noted migration, I would say, over time towards our standards and the content over the decades to become more and more inclusive, more and more nuanced, more and more sophisticated. A number of years ago, I was doing a review on the history of tobacco control as a presentation, and that took me back to Surgeon General's report, 1964, and before that. And what I noted was the very first Ontario Public Health Standards had no content about tobacco, and were very simple, right? So we've expanded over the years to include more things. And I think there's nothing new then about having to grow in public health as issues arise. At first, there's the early adopters among us that start addressing them, and eventually they get codified in our standard. But I think many of us are way out ahead of the standards. Those have to deal with something first. So it's not a new thing to be asked, how do you deal with complex new problems? Because it's been happening the whole of our history. And data has always been an important part of that. Same with future projecting as well. So in our, a number of health units have, for example, taken on climate change and asked the question, what do we do about that? The ultimate of complex topics, the ultimate of a long-term concern, global in nature, what can you possibly do locally? And had taken a vulnerability assessment approach, which inherently involved looking ahead to the 2080s, right? And using complex data sets from other sources like the Ministry of the Environment or Health Canada and other expertise external to us to achieve it. So I think we're up for the challenge. We always have been.
Sure, so there was a lot of elements to that question. So I'll just talk about the getting out of our comfort zone and going back to data. So the one interesting thing about using data is that we can generate all these interesting analyses. And what they do is they shed light on things that maybe say that what we're doing isn't working and we need to shift. But my experience is that's a really hard thing to take in when you have so much passion, everyone's committed, but all of a sudden we're saying, actually, things aren't working out, and maybe we should be shifting our focus over here. And somehow we need to get better about that and getting out of our comfort zone and thinking about things that are a little difficult and realizing that maybe something that we've been investing in or the way that we've been rolling it out actually may not be the most impactful way forward. And it's not because it was wrong or it was the wrong thing to do, or we were misinformed, but we need to adjust a little. And that's the fundamental basis of the idea behind a learning health system. And I'd like to see some of that thinking around what a learning public health system looks like. How do we use data to shift how we move? Inevitably, that will take us out of our comfort zone, absolutely. And how can we be better set up to respond to that in a more nimble way?
So one of the things that sometimes happens when you give people in health a big problem is that they decide they have to rush to action, but they also decide that they have to do everything. And that often freezes people eventually. And one of the things that always happens when you're trying to do these things, the first thing obviously is an analysis of what the problem actually is. The second is an analysis of who's already doing things in different areas and how you can help them. And then the third thing is what levers do you have to move things forward. And obviously choice of the problem and being sure that you've got a way of moving things forward is quite important. And some of the learning is, we've got to learn new skills. Some of the learning is we've got to learn how to partner, and some of the learning is that we can learn new skills while we're working with other people. Because this idea of creating communities that function, that are healthier, is not new. And it's not like we don't necessarily have the skills somewhere in Ontario or somewhere in Canada or maybe internationally to move things forward. The question usually is whether we've done the analysis to work out what we need to do in order to move things forward, and whether we've decided how we're going to choose where we're going to start. Because it's quite important to have quick wins, medium-term wins, and long-term wins if you're setting a strategy to move forward. And so if you don't have a strategy, I think they used to say, if you haven't got a plan, you'll plan to fail. But the truth is, if you haven't got a plan, you will be planned, which is a much more paranoid position to take. But it is true, because that's how things work.
I had planned to say many of the same things, not as eloquently as you certainly have. But I think that we cannot boil the ocean, and we need to think about what the strategic points are within this complex system where we can actually push. The hopeful thing about complex adaptive systems is that sometimes impacts will be greater, not just linear and proportional to the resources that are invested. But we need to actually identify what the strategic points are going to be. The other point I would like to make is that the complexity, in fact, as we heard from the presenter yesterday, is a multi-level construct, right? It's from individual right through to societal level. And as individuals in different roles, we'll have to think about how we actually exercise those. It could be that the most impactful place to push might be at a macro level, but it might be a reach too far in some instances. And it might be better to live another day and find a way to actually build a broader network. One of the lessons from the tobacco control strategy was the strength of building a local movement that was then able to push more macro strategy.
I'll borrow over just for a quick comment, but certainly all the valuable points there. And I guess I was playing on what Kwame was talking about, minding the gap. And I didn't know the story behind it, but it meant something. And in the discussion we're having here, I think I was looking at it the other way, because I do the commuting, and I saw the sign, mind the gap. And I was doing that, but everybody else was pushing and shoving, and I was rather indignant that they weren't minding the gap. And the first thing that came to me in mind is that you had to gap the mind. And I didn't understand the perplexities they were dealing with it. So if everybody could just do it the way I did it, society would be a lot better. It doesn't work that way. But sometimes we have a pretense, we push to go that. Sometimes we assume that governments make decisions because it's very much that aspect that's in there. But when we go back and behind it, we find that's generally what our public and our community actually feel. And that may be surprising to us. And we have a bigger task to do with education. We're doing this whole thing around the opioid crisis. Hearing the different vulnerable populations come forward was an eye-opener learning experience, because my assumptions, much as I said at the beginning with First Nations, I assumed there was a problem. I had no idea what the context was behind it. I didn't understand the gap in my knowledge base to address those issues. And sometimes our first step is to say, maybe I don't have the whole picture. Maybe the data I have isn't the best data. Maybe it's not the most comprehensive. And same with the other issues around that, where there's still a lot of people out there, unfortunately, a large percent that say, well, people with drug addictions are people who just make bad choices, and I guess they're going to die, they might as well do so. And we still have, I'm not talking about a few, I'm talking about a large percent of our public are still caught in that mindset. And while we may be convinced and other things, they are not convinced. And that doesn't mean we can write them off, because we're dealing with a society polarized, and these issues are huge ones. And we have to ask ourselves, how do we engage in that dialogue? And even in our sense of righteousness, we may want to push our mind. That doesn't mean it may be the rest, and we have to see it from both sides. So I like that analysis. So I'm going to gap the mind, keep working at that.
I think we have a question at mic 3, Dr. Doug Sider.
Peter, I'm sorry you turned around and saw me at the mic and you blanched a bit, but there's an elephant in the room that I want to address, and I raised... Hello? Oh, I thought they'd shut off the mic. As people who know me, I wouldn't need a mic anyways for this. I don't think it's evidence-poor hyperbole to note that the current provincial government shows many, many policy dimensions, whether it's social, educational, income, employment, environmental, that it's committed to increasing health inequities. Could each of you, from a very unique and important perspective, talk to strategies that address the disconnection between the importance Heather, as you said, of our legislated objects, and yet the particular governmental political policy terrain that we're facing at this given moment.
Heather?
You know, I had a question prepared for an answer prepared for the last question. Doug, you've asked a very, very challenging question. Thank you very much, as always, for your challenge. Doug, I've discovered, is a really interesting person. And in fact, Doug, I'm going to call you out for a reason. It does go back. I'm going to answer this other question first, if that's okay, because I got to think through what you've said, and I'm giving my panel time to think. In terms of solving complex problems, it's actually the answer to how you do it is to listen. And it's to listen to the voice of the community, and it's to listen to unique voices. And oftentimes these are marginalized voices. Initially, they have the most creative and innovative ideas. And Doug, I'm going to call you out as being somebody who also has very creative and innovative ideas. And even your idea of asking that very challenging question for me is quite a creative idea. I'm sure you're aware that in Public Health Ontario, we don't advocate, we just keep doing the job that we do. We've got our mission and mandate, we respond to our legislated objects. We're there to provide scientific and technical advice to whatever government happens to be in power, to protect and promote the health of Ontarians and to reduce health inequities. My team, and the rest of the staff at Public Health Ontario, under Peter's leadership and working with all the directors and VPs and managers, will continue to do that. There we go.
So I think shall I move on? I think it's quite important. One of the things I worked with the last government. I haven't worked so much with this government as yet, but I think it's important to remember some of the things that Chuck was saying and others. The inequities have been increasing since about 1991. 1991 was the last time we had a Gini coefficient that was anywhere near 3. And it's been increasing since. And so it's been increasing under all shades of government. And it can be easy to think that you have to be left-leaning or right-leaning, but I think we have to pull back and actually be health-leaning and keep authentic and keep to thinking about health and the social determinants of health and what under any government one can do to try and decrease inequalities. I'm not being an apologist for the current government or the previous government. The governments are elected, and the question we have is how we can lever the best health for people under the government that's in power. And you have to be, and I think we have to be respectful of the process and respectful of what we can do to move things forward. So I do believe in advocacy. I do believe in working with communities. I do believe in working with other stakeholders, but I also believe in working with government and the bureaucracy to make them aware of the choices they're making. So when I'm talking about thinking about divisive social or economic policy as being a social determinant of health, I'm talking about making sure we're very clear in the conversations that we're having and that the population is clear in the conversations it's having and that some political decisions are health decisions. And they can make their choices at the ballot box when next they have a chance to do so. And being able to educate people, have those conversations, and have an adult conversation about what's going on is the way that democracies work. And you know, I believe in democracy because it's the best of the systems that we've had so far when it's working.
Just to build on themes that have been already stated, I too believe that that is the question of the day. I think I personally need to speak more to not so much the cutting edge of what we are moving towards with a more sophisticated, richer mandate, but our base. Like in this time, it's always, I think it's important for the government of the day and for the population actually to understand what we've always done, the traditional things that we've always done in the realm of health protection, safe food, safe water, vaccines, communicable disease response management that are absolutely fundamental that this government needs to respect and protect and maintain. because it's absolutely essential and it's entirely in their interest to maintain it. So I would say right now we are reminding them of that, seeking to protect the integrity of the public health system itself. And to look to the long term as well, because the deeply embedded social issues of the day indeed are long term. And so as we protect our system, we prepare ourselves to be able to be around to carry on the conversation with government about policy and the social determinants of health and indeed the impacts of their decisions. And if you get traction now, that's great. You will eventually get traction, if not today, on those issues.
Yeah, just 2 points to add. One is, again, inequities have been increasing, and it's not one government or the other. It's actually a series of more complex issues. So that's really important to emphasize. But also to emphasize that forward-looking piece that I was talking about earlier, because the decisions that we make today actually are going to manifest 10, 15, and 20 years from now. And some of, again, the benchmarking work has showed us that some of the healthiest countries have a 20-year look forward on policy decisions because they know that the health impacts will be generations, and we're probably living the impact of decisions that were made 20 years back or earlier. The other thing I'll say is that I think it also comes with framing. So whatever political position you're talking to, reducing health inequities and having a healthier and more connected community is good for, yes, population health. It's the right thing to do. It also reduces healthcare costs. It also increases GDP. There's a reason why the OECD does a happiness report, because the most productive countries are actually the ones that have the citizens that are the happiest, that feel the most socially connected. So I think we can work a little bit on the framing of our issues.
Hi, let's go to mic 1. Sound? Could you direct your question? Sorry, could you direct your question to one of the panelists? We're running fine on time, I'm being told.
Okay, sure, thank you. So I want to thank everyone for bringing up this idea of belonging as a driver and contributor to equity and inequity. I've really believed that's true for a very long time. So it's great to hear that the Chief Medical Officer of Health actually agrees with that. My question is about how do we use qualitative data to help understand the impact and experience of belonging on those inequities, and how do we integrate it into our reporting and accountability structures to get a fuller picture of how our communities are really experiencing belonging and the process for creating belonging and sustaining it so that those inequities don't persist. So maybe that's a good question for Dr. Rosella and Dr. Williams.
Sure. So the way I look at all analytics, and that includes from quantitative and qualitative sources, is that we have a toolbox, right? We have data and we have a toolbox to draw from to tell a story of what's happening. And we should not be confined to one particular tool, one particular method, one particular way. We have to actually draw on all of these where appropriate. And so I think the reports did an excellent job of this, actually, bringing together both quantitative and qualitative. You absolutely need both. And how we do it in a more structured way, there's lots of opportunity to talk about that. But I think we need to get out of the thinking that we must present data and information a certain way. We must use the best tools for the best purpose and draw on all tools as much as possible.
Okay, thanks, Laura. Let's go to the gentleman at mic 2, and then because we have to wrap up in a moment.
Oh, hi. Thanks. Eric Young, semi-retired deputy PHO for BC. I'd just like to address a comment to the members of the panel because I think it fits with a lot of what you said. I think that you've talked a lot about the importance of data, and in public health we've moved from the collection of data on illness and disease to now looking at data on well-being and publishing information on that. But I think we need to move to the next level of data first, and that is to look at the roots of the causes of our problems. So somebody a long time ago said that there are thousands of people hacking at the branches, but very few people looking at the roots. And so I think some of the things, we need to act more like the transnational corporations. We need to look at what is the legislation in place that is leading to the system that we have that causes the outcomes that we're seeing. Because that legislation, whether it's provincial or federal, contributes to the set of circumstances and the system that we're all in. A lot of that legislation is the result of an incredible amount of lobbying by corporations to get the legislation in place that they need. And some corporations don't have legislation that's actually that good for us. So nobody seems to be actually pulling that data together and giving it to public health. The next piece is, what are we doing with the analysis around justice and how that's being applied in the country? Because that makes a difference to equity. What are we doing about looking at education and the rules around education and the opportunity it's providing to the people who don't have that kind of access? And then next, the data I think we need is around corporate lobbying, because corporate lobbying has a huge effect on government. If you saw the corporate lobbying around NAFTA, there was a ton of it around put this and that and the other thing into place by corporations, and very little by public health, because there's not enough capacity. But we're not even keeping track of all of that lobbying, the lobbying in Canada that's going on by the oil industry to fight climate change strategies that the rest of us think we need to be doing. But if there are hundreds of lobbyists and we're not even aware of it, the other thing we're not keeping track of in terms of data is how many opportunities are there for us in public health to actually contribute to the discussion at the Senate committee levels federally, at the parliamentary committee levels federally. Who's keeping track of that, and who's advising us all that, hey, here's your opportunity to go and talk about energy drinks or vaping and why nicotine is being allowed in that so we can addict all our teens. So it seems to me that we need to actually start getting the data at another level and handing it out to everybody so that then we can actually start working on hitting those areas of the base of the system where we can make a change. Because otherwise we're just always sticking our finger in the dike or doing things that look to us like upstream, but actually when you look at the system, it's midstream or even sometimes downstream.
Thank you. Thank you. You do that. Dr. Williams is going to respond to that.
Is this one working? Yes, I believe it is. Thank you, Eric, for those questions, number of questions. And I think building on what we've heard in the discussions today is that, as I was saying, sometimes with our data, we take the data and we analyze it in a way that seems to be correct to us. One of the things I've always found with dealing with outbreak and outbreak management is that we have to ask what we don't know, not what we do know. And sometimes we drive to conclusions fairly quickly because we feel the pressure to do as Kwame said, and we don't understand the impacts of that. And so we have to critically always appraise our data to say what it tells us, and more importantly, what it doesn't tell us. And I think in the discussions we're engaged at many different levels, and we're having more and more federal, provincial, territorial meetings, more roles and changes. So as our structures are changed at the federal level, at the different provincial levels and territorial levels, as public health is involved at different levels in different areas, I find there is a certain strong appetite to hear from public health. Sometimes we come with the issue, we don't have the data that's comprehensive enough to supply some clear decision making. I think we've all had the case where we made decisions we felt was well-founded, it was based on really solid data, and we found out later that while we improved some situations, we made it sometimes worse for other people with those decisions. We didn't know, we didn't really understand that, and that's part of the humbleness and the humility of going through the process. And whether it's government groups making that with the dull tool of legislation or other ones around there, we try to bring all the stuff to the table and enough that decision makers, and they always want to try and make the best decision they can on the priorities they're trying to deal with in that. But if we don't give them the comprehensive data in a way that's digestible, understandable, meaningful, then we'll be going along the line that Eric said, we'll have those gaps and those spaces. So our challenge is always that while we may think our data is solid, we might think the position, we may think we're speaking on behalf of the community, we always have to ask ourselves, is it that good? Are we speaking on behalf of the community? What part of the community? is it fair and equitable? Because sometimes we can be the instruments of inequity as well as the carriers of that message. So I always have to have that lessons of humility comes back to bite me and saying, you didn't take a wide enough look at this issue, and what do we have to do? So it's a learning process, edifying each other in this one, and so I thank you for that, and I think we're getting the music starting to play in the background. But I would like to thank the panelists, and these are only some that were involved in the committees. And as I said before, you can hear the passion and interest is there from all of them. And I am greatly edified by those comments, continue to be edified. And there's others that aren't here today that have done that. And that's what I found as a valuable process. And that's one of my problems in my job and the busyness of it. As someone said, in the business of hearing the stuff, how do you, someone used the phrase, how do you squint your ears? To hear the messages at the right time with all the noise and that. So I'm going to try and keep listening. You have to keep trying to talk and get my attention on the right things, and we'll try and do our best as we try to move the portfolio. Not that any of us, including myself, has any pretense of getting it perfect, but perhaps we can take the problems of today and make them slightly less for tomorrow and help in those areas there. So I'd like to thank the panelists and my team who did all the work. I just get to get up here and talk. They do all the work of putting it all together and keeping me in line. So I'll end with that.
I do want to thank Dr. Williams and the panel for your thought-provoking presentation and discussion. The focus on data, health equity, and community from the various perspectives, I know at a personal level will cause me to reflect on the work I do in public health, maybe sometimes at a very micro level, but moving on up. So thank you again for all your expertise. We are going to move into a break for the next little bit. I do ask that you visit the exhibits in the foyer. They have great information available. We will come back to the break, from the break into this room for 10:30, at which time we're going to hear from Professor Stephen Hoffman on a topic talk session. So go for break and we'll see you at 10:30. Thanks.